Good morning, everyone. In the 100-day study challenge that we started, today we have a new episode about angina pectoris. We'll study it today. Angina pectoris is a favorite exam topic, so let's start. With the first question, a nurse is assessing 4 clients who report chest discomfort. Which patient is experiencing stable angina pectoris? This means we must choose the patient with the stable type of angina pectoris. Now look, angina pectoris occurs when there's a mismatch between the heart's oxygen demand and its oxygen supply. That is, demand is high, but supply is low. This causes ischemia in the heart cells, meaning an oxygen deficiency, which starts the chest pain we call angina pectoris. Angina means pain, and pectoris means chest, so it's pain occurring within the chest. But since the stable type was asked, we have several types of angina pectoris. Stable angina pectoris means it's stable or predictable, meaning we can anticipate it. We can predict that if a patient is exercising, they'll have pain, but if they stop, the pain will stop. Or if a patient is climbing stairs, they'll have pain, but as soon as they stop, the pain stops. If a patient is running, they'll have pain because oxygen demand has increased, but supply has decreased due to a blockage in the coronary artery. That might be why the supply decreased, which causes the patient to have chest pain. So from this, we can predict that this pain increases due to exercise or increased physical activity. This means we can predict it. Or, for example, if a patient has pain but we give them nitroglycerin and after taking it, the pain goes away. This means we can predict these things. So this is called stable angina. The second type of angina is unstable. Unstable angina pectoris, meaning we can't predict anything about it. The chest pain has an unpredictable pattern. For instance, even if the patient is just sitting, the pain can start. This means the patient has pain without activity, or even after being given nitroglycerin, the pain isn't relieved. So we call that unstable. Unstable angina is a more serious condition because it tells us that at any time it could turn into a myocardial infarction. Look, in angina pectoris, there's only ischemia, meaning oxygen deficiency. But in myocardial infarction, there's infarction, meaning the tissues start to get damaged. The cardiac tissues themselves begin to suffer damage. So we've seen these two types, stable and unstable angina pectoris. There's one more called variant angina pectoris. And with variant angina pectoris, we can tell from the name that it varies. Vary means different. This means it falls into neither the stable nor the unstable category. It's different. It varies. Hence, variant angina pectoris. In this case, spasms begin to occur within our coronary artery. In this condition, there's no fat plaque buildup in the coronary artery, nor is there any thrombus or emboli. But what happens is that our coronary artery starts to spasm, like this. So we call the variant angina pectoris. Its other name is Prinzmetal angina pectoris. It's called Prinzmetal because the scientist who discovered it was named Prinzmetal, so it was named after him. So those were the 3 main types of angina we have. Now, we have to identify which one is the stable type. Now, remember that stable means predictable. This means if we remove certain triggers, the pain will go away. Because once we reduce the trigger, say if a patient is running, climbing stairs, or exercising, their heart has to work harder and pump more. This increases the demand, but the supply is limited, possibly due to fat plaque in the coronary artery, which reduces that supply. So as soon as that trigger is reduced, the pain will also subside. Now, why does this pain occur? To explain, our heart has 3 layers. The outermost is the epicardium, the middle is the myocardium, and the innermost is the endocardium. This is the heart. Now, the vessel that brings the blood supply here is the coronary artery. That is, the coronary artery supplies blood to the heart wall. Let me zoom in a bit to show you. Blood flows through this coronary artery. When blood flows, and I'm talking about normal conditions here, glucose arrives, and there's also oxygen in that blood. So glucose plus oxygen combine here to create glucose plus oxygen. We call metabolism that occurs in the presence of oxygen aerobic metabolism. And whenever aerobic metabolism happens, ATP is produced. Now this ATP is formed, and once it's there, the cells get the energy they need, allowing for contraction. So no lactic acid is produced here, which is why there's no pain. But why is there pain in angina pectoris? It's because a fat plaque has formed somewhere in this coronary artery, or a blood clot, called an embolus, has arrived from elsewhere. Or if this plaque ruptures or bursts, a clot starts to form there. This reduces the oxygen supply. If less blood arrives, there's less oxygen, or no oxygen at all. So the metabolism that was occurring will now happen in the absence of oxygen, because our oxygen levels are low, or very low. Therefore, some metabolism will take place without oxygen. Now, if it occurs in the lack or absence of oxygen, it's called an AN. An means absence, so we'll call it anaerobic metabolism. And whenever anaerobic metabolism occurs, instead of ATP being formed here, lactic acid starts to form, and it comes out of the cell like this. We call it lactic acid. This is lactic acid. So lactic acid will be everywhere here, outside the cell. This lactic acid will irritate the nerves that are here. These yellow lines I've shown are the nerves. Now, the more lactic acid there is, the more these nerves will be irritated. These nerves will get irritated, and that means there will be pain. So this was the reason for the pain, and since it's in the chest, we'll call it angina pectoris. Now, suppose we've reduced the activity, meaning we've reduced the demand. The demand is reduced. This means the heart has to work less now, or we've given nitroglycerin. If nitroglycerin is given, then this coronary artery will dilate. If it has dilated, just like the coronary artery has become like this now, if it's dilated, it means more blood will flow through here. As the blood reaches here, it means the supply has increased. The supply increased, which means oxygen will arrive here. And as oxygen arrives here, then glucose plus oxygen will metabolize together, so that will be aerobic metabolism. If it's aerobic metabolism, ATP will be formed. Since ATP is formed, lactic acid won't be produced anymore. So now this lactic acid will disappear. From here, as soon as the lactic acid disappears, well, it was this lactic acid that was irritating these nerves and causing pain. Now that the lactic acid is gone, the pain is gone. This means the patient will then get relief from the pain. So now let's see what our options are saying. We have to look for the stable one, which is predictable. We know that these specific things will cause pain, or these specific things will reduce the pain. A patient with chest pain at rest lasting 20 minutes. 20 minutes, that means it's a very long time, whereas angina pain lasts for a short time. That is unrelieved by nitroglycerin. This means even after giving the patient nitroglycerin, this pain didn't go away. Nitroglycerin was given, meaning we increased the supply by dilating the coronary artery, but despite that, there was no relief from the pain. So this means it has become unstable. So this one is unstable angina. Because in unstable, what happens is that even when we remove the trigger, or if we increase the supply, there is still no relief from the pain. So that's called unstable angina pectoris. So we'll eliminate this one here. Next, a patient with chest pain during exercise that is relieved by rest within 5 minutes. This means there's a patient who is exercising. So because of exercise, what happened is that due to exercising, his heart had to pump more. It had to pump more, which means it had to work harder. This means the heart's workload increased, and the workload increased. This means the demand increased. For oxygen, the demand for oxygen increased, but the supply from behind is limited because inside the coronary artery there might be a plaque of fat there. So because of that, what happened at that time was that lactic acid started to form. Due to anaerobic metabolism, as soon as lactic acid was formed, the pain started there. But as soon as he stopped exercising and rested, he got relief from the pain. And this is exactly what we saw, that in stable angina pectoris, as activity increases, pain occurs, and as activity decreases, the pain stops. So we call this stable angina pectoris. In this, the pattern is predictable, meaning if we tell him to exercise again, the pain will return. But as soon as we tell him to stop, the pain will go away. So, sorry, this option here is an example of stable angina, a patient with chest pain occurring at night due to coronary artery spasm. meaning the pain that occurs at night due to a spasm of the coronary artery. We call that variant angina pectoris or Prinzmetal's angina pectoris. In this, what happens is that within our coronary artery, the innermost layer, which we call the endothelium, produces nitric oxide. It produces nitric oxide, and the more nitric oxide there is, the more vasodilation occurs. Now, if vasodilation occurs, it means the coronary artery is dilated, so the supply will continue. But in patients where this nitric oxide starts being produced less, now that nitric oxide production has decreased, nitric oxide production has decreased. It means vasodilation has also decreased in it. This means the chances of vasoconstriction are higher here. So in such patients, at night, this coronary artery will spasm. Why does it happen at night? Because at night, due to our parasympathetic stimulation, contractions start occurring within it, or the temperature also drops at night, and the lower the temperature or the colder it is, the more the pain starts in the patient, because a spasm will occur at. So we call this Prinzmetal's or variant angina pectoris. Lastly, a patient with increasing frequency and severity of chest pain over the past week. Now look at what's written here. Increasing frequency, meaning the frequency is rising, and chest pain over the past week is increasing, which means it's becoming more severe. So this is an example of unstable angina pectoris. So this won't be it either.
Before we move ahead, here's something you shouldn't miss. If your goal is to pass the NCLEX in just 1 week or 1 month, then the fastest and most effective way is to enroll in our complete online NCLEX review crash course. This course is a one-stop solution, a reliable shortcut, and a proven method with a solid 99% passing rate. More than 5,000 students have successfully passed the NCLEX by using this course. Here's exactly what you'll get. 100-hour mini crash course perfect for those who want to pass within a week. 300-hour comprehensive lectures covering 300 essential NCLEX topics that are commonly tested. 5,000 real NCLEX questions. Prepare with real exam questions and eliminate surprises. 15 full practice tests, including CAT simulations, simulate the real exam for a stress-free experience. Exclusive ebook plus 1-year access. Study whenever and wherever you want. Seats are filling up quickly. Enroll now to save 70%. Visit our website to enroll in our complete NCLEX review crash course. The link is in the description. Now, let's continue with the topic.
A 63-year-old patient is diagnosed with Prinzmetal's or variant angina. This means it's the type of angina pectoris that occurs at night, and in this angina, there's no clot in the coronary artery, nor is there any fatty plaque. What happens is a spasm in the coronary artery. Due to the spasm, it is narrowed. Because of the narrowing, the oxygen supply to the myocardium is decreased. Which medication is most appropriate to manage this condition? Which medication will we give? Propranolol, which ends in lol. That means it's a beta blocker. Now in this case, we need to give a medication that dilates the coronary artery. Propranolol is mostly a beta blocker, and where do beta blockers work? Inside our heart, within these SA nodes, there are beta receptors. And what it does to the beta receptors, well, this propranolol, we know it's a beta blocker. This means it will block them. And the beta receptors, the more active they are, the higher the heart rate will be. So the more active the beta receptors, the more impulses will be generated from this SA node. The more impulses generated, the higher the heart rate will be. The higher the heart rate, the more the heart has to work. This means the heart's workload will increase. The heart's workload increases, which we don't want. We want the heart's workload to decrease in angina pectoris. Now, this propranolol falls into the beta blocker category. It will come and block this. By blocking it, it reduces its activity, and that means the heart rate will decrease. So what this does is it's lowering the heart rate. But where is the problem? You have to see that Prinzmetal's or variant angina, and what happens in that is that our coronary artery is undergoing vasospasm, so we need to treat that root cause, which is to relieve the vasospasm. So we won't give this because it lowers the heart rate but doesn't relieve the vasospasm. Next is lisinopril. Any drug that ends in pril, you should understand that it's an angiotensin converting enzyme inhibitor drug. These are The dosage of lisinopril was reduced. Yes, the next option is lisinopril. Now, any drug ending in pril is an ACE inhibitor. That is an angiotensin-converting enzyme inhibitor. And this angiotensin-converting enzyme is found in the lungs. The angiotensin-converting enzyme is in the lungs, and it converts angiotensin 1 into angiotensin 2. Once it's converted to angiotensin 2, it causes our blood vessels to contract, which leads to an increase in blood pressure. So when we give an ACE inhibitor, it means it will reduce the ACE, the enzyme being produced in the lungs. It will reduce it. This means it prevents angiotensin 1 from converting into angiotensin 2. If it doesn't convert, meaning no angiotensin 2 is formed, then blood pressure will decrease. So we want the workload to decrease, meaning lower BP to reduce the heart's workload. But even here, the root cause isn't being treated. Students might choose this, thinking this drug lowers BP, which would relieve the angina, but no, we must treat the root cause. So this drug primarily works on the RAS system, the renin-angiotensin-aldosterone system, to lower BP. But it doesn't resolve the coronary artery spasm. Therefore, we'll eliminate this option as well. The next drug is nifedipine. Nifedipine is a calcium channel blocker. What calcium channel blockers do is, within the muscles, say this is a muscle, and inside that muscle, this is a cell. Now, when calcium enters this cell, the muscle contracts. If calcium doesn't enter, there's no contraction. So if calcium is entering, it means contraction is occurring. These calcium channel blockers will close these channels. They block the channels through which calcium enters the cell. If these channels are closed, calcium can't get in, and if calcium can't get in, there's no contraction. This means it prevents the contraction of smooth muscles. So nifedipine prevents the contraction of smooth muscles within the blood vessels by blocking calcium channels. By blocking them, calcium won't enter the smooth muscles, and without calcium, they won't contract. The middle layer of the coronary artery consists of smooth muscle, so it will prevent its contraction. This means if we give this drug, the unnecessary contraction in the coronary artery will stop. So this is the drug we'll use for variant angina. Next is dobutamine. What dobutamine does is it strongly activates the beta receptors. If it activates them, the heart rate will increase. It activates the SA node, meaning it activates the beta receptors, so the heart rate goes up. A higher heart rate increases the workload, and an increased workload will worsen the angina, which we don't want, so we won't give this either. Aspirin. Some students might choose aspirin thinking it's angina pectoris and will give aspirin to prevent a clot, but that's not the case here. Because in this type, meaning our variant angina or Prinzmetal's angina, there's no clot or fat plug. What happens is a coronary artery spasm. So we don't need a drug that prevents clot formation. We need to choose a drug that stops the spasm. A client with chronic stable angina has elevated cholesterol levels despite lifestyle modifications. The physician prescribes atorvastatin. Atorvastatin, this means it's a fat-lowering drug, a drug that reduces cholesterol. Which statement by the client indicates correct understanding of the medication's side effects? So we need to find the true statement, meaning due to atorvastatin. What side effect can occur, we need to see. This medication may cause muscle pain. Yes, whenever we give a patient a statin Vastin, it causes rhabdomyolysis. Rhabdomyolysis, what happens in this is it causes rhabdomyolysis. Rhabdo means skeletal. Myo means muscles, and lysis means breakdown. So there are chances of rhabdomyolysis whenever we give a patient atorvastatin, and this rhabdomyolysis means the breakdown of skeletal muscles. And whenever skeletal muscles break down, myoglobin is released from those muscle cells. And this myoglobin goes and gets stuck in the filtering units of the nephrons found in the kidneys. Because of that, renal-related problems might start in the patient. So whenever this muscle pain occurs in a patient, we can guess that if we continue this medication, rhabdomyolysis could occur, which is a very bad condition. So this is a true statement. It means the patient is aware of the side effects of this medication. Next is, this medication may cause palpitations. No, it doesn't cause palpitations. This medication may improve my vision. It has nothing to do with vision. A patient presents to the emergency department with severe, crushing chest pain lasting more than 20 minutes and not relieved by rest. This means there's chest pain that lasted for more than 20 minutes and wasn't relieved even after rest. So now we can think that it's not stable angina. This is unstable angina. This clinical presentation raises immediate concern for a life-threatening cardiac event. Which diagnostic test should the nurse anticipate as the highest priority to differentiate angina from an acute myocardial infarction, MI? This means we're being asked which test we perform for this patient. Which test would be given the highest priority? So a 12-lead electrocardiogram. A 12-lead electrocardiogram is something we perform within 10 minutes of the patient arriving at the hospital. This tells us if the patient's angina pectoris has progressed to a myocardial infarction. In other words, has tissue death started within the myocardium. What happens is, as we've likely heard, there are two types, STEMI and NSTMI, meaning street-elevated MI and non-street elevated MI. This helps us determine if the patient has angina pectoris or a myocardial infarction. We can easily observe this, perform it on the spot, and get immediate results. So this is our primary choice. Next is the cardiac troponin level. The cardiac troponin level also indicates myocardial damage, but whenever there's myocardial damage or infarction and tissue is damaged, it only starts to rise after 3 hours. This means if a patient just had an infarction, it won't increase for 3 hours. It only starts rising after that. So this won't give us an immediate answer. However, if the question asked for the most definitive, most specific, or most confirmatory test to confirm if the patient has angina pectoris, then we would choose the cardiac troponin level. If asked which is the most specific for myocardial infarction or the most definitive, we'd say cardiac troponin. But here, the question asks for the highest priority to differentiate angina from myocardial infarction. In this case, since we need an immediate test, we must perform an ECG on the patient. As for the exercise stress test, no, we won't do that because the patient already has severe angina. If we perform an exercise test during severe angina, oxygen demand will increase, which could worsen the angina pectoris and cause it to progress into a myocardial infarction. So we avoid that. Holter monitoring involves monitoring the patient's ECG over a 24-hour period. We won't do that either. A chest X-ray shows us the shape of the heart and lungs and other details, but for this specific condition, a chest X-ray isn't helpful. A patient with suspected angina pectoris undergoes an exercise stress test. An exercise stress test means the patient is currently running on a treadmill. Which finding most strongly indicates that the angina pectoris is stable during the test? This means, during the test, which of these options indicates that the patient's condition is stable?
Before we move ahead, here's something you shouldn't miss. If your goal is to pass the NCLEX in just 1 week or 1 month, then the fastest and most effective way is to enroll in our complete online NCLEX review crash course. This course is a one-stop solution, a reliable shortcut, and a proven method with a solid 99% passing rate. More than 5,000 students have successfully passed the NCLEX by using this course. Here's exactly what you'll get. 100-hour mini crash course perfect for those who want to pass within a week. 300-hour comprehensive lectures covering 300 essential NCLEX topics that are commonly tested. 5,000 real NCLEX questions. Prepare with real exam questions and eliminate surprises. 15 full practice tests, including CAT simulations, simulate the real exam for a stress-free experience. Exclusive ebook plus 1-year access. Study whenever and wherever you want. Seats are filling up quickly. Enroll now to save 70%. Visit our website to enroll in our complete NCLEX review crash course. The link is in the description. Now, let's continue with the topic.
That the angina is the stable kind, stable angina pectoris. So chest pain occurring with minimal exertion, meaning chest pain occurs even with very little activity. So if the patient is experiencing chest pain with even minimal activity, it means it's not stable. It would fall into the unstable category, but we need to identify the stable one. Next is ST segment elevation on ECG. Whenever there's street segment elevation on an ECG, we can say it's a STEMI or STEMI. This indicates a myocardial infarction, specifically a STEMI, meaning street segment elevation indicates an MI. This means the infarction in the patient is quite extensive. It's what we call transmural damage has occurred. Transmural means, for example, in this myocardium, if there's only a little bit, if only a small area of tissue is damaged here due to lack of oxygen, not all of it, just a portion, then that would be a non-STEMI. But if the entire myocardium is damaged, meaning transmural, from this side all the way to here, it's completely damaged, then what happens? The saint segment will elevate, indicating a complete blockage of the coronary artery, leading to transmural myocardial damage. So this indicates a myocardial infarction, but we need to find the one that indicates stable angina pectoris. That one is for myocardial infarction. No chest pain until the patient reaches a specific heart rate threshold. This means when we started the patient on exercise during this stress test, when we started them on the treadmill, there's a fixed heart rate limit, and until that heart rate is reached, there's no pain, even as they continue to exercise. It means pain only occurs after reaching a fixed threshold. This means we've predicted that pain will occur once this specific heart rate is reached. So it's predictable. And predictable means it's stable. So this will be our answer. Next, elevated troponin levels after the test. If troponin levels rise after the test, troponin levels only increase when our myocardial cells are damaged. Cell damage means a myocardial infarction. So this indicates an MI, whereas the question asks about stable angina. So this is also wrong. A nurse is educating a patient with angina about the proper storage of sublingual nitroglycerin tablets. Which statement by the patient indicates correct understanding? This means we need to identify the correct statement. A, I can store the tablets in a pill organizer if I keep them away from sunlight. This means we shouldn't keep them in a pill organizer because a pill organizer isn't airtight. Because of that, the medication's effectiveness will decrease. So we don't store it in a pill organizer. B, I should discard the tablets if they are older than 1 year. 1 year is too long. They should be discarded after 6 months. This means this is also wrong. C, I need to keep the tablets in their original dark container and close it tightly. Yes, in this case we use its original dark container. Keep the nitroglycerin inside it and ensure it is closed tightly. So if you close it tightly, air won't get in. And it's a dark container. The original dark container for nitroglycerin prevents light from getting inside, so this means that light won't cause any damage to these nitroglycerin tablets. I can keep them in my car's glove compartment for quick access. Now, if you keep them in the car's glove box, then, due to air and light, the effectiveness of the nitroglycerin will decrease. A patient in the cardiac care unit reports chest pain. On assessment, the nurse finds that the patient is hypotensive. The patient has an order for sublingual nitroglycerin. This means the patient has hypotension and sublingual nitroglycerin has been ordered for them. What is the nurse's priority action? So what will the nurse do? First, we need to understand that nitroglycerin causes vasodilation throughout the body, whether it's cerebral vasodilation or coronary vasodilation or vasodilation anywhere else in the body. It happens all at once. But if the patient already has hypotension and we give them nitroglycerin, it will cause even more hypotension. And if the hypotension worsens, the patient could go into shock. Furthermore, if the patient's hypotension worsens, the blood won't even reach back to the heart. If it doesn't reach, then no matter how much you dilate the coronary artery, the cardiac output will decrease. If cardiac output is low, blood won't reach the coronary artery either. So what should be done now when the patient has hypotension? Encourage the patient to walk to relieve the chest discomfort. If we tell the patient to walk more in such a condition, the oxygen demand will increase, which will harm the patient even more. So we'll eliminate this. Administer the prescribed dose of nitroglycerin. If we give the dose of nitroglycerin to the patient but they have hypotension, it will cause even more hypotension, which we don't want. Withhold the nitroglycerin and notify the healthcare provider. Yes, we must withhold it and inform the doctor. Administer half of the prescribed dose of nitroglycerin. Now, we can never half or double the drug's dose ourselves. A patient diagnosed with angina pectoris is prescribed atenolol. Anything ending in "lol" means it's a beta blocker. And what will these do? They'll go to the SA node in the heart and block its activity. They'll block it, which means they'll decrease the heart rate. The nurse understands that this medication helps to relieve the angina primarily through which mechanism? This means they've asked for its mechanism. Increasing the blood pressure to improve coronary perfusion? No. If it increases the blood pressure, well, we don't want that. If blood pressure increases, it means the cardiac workload will increase. If the cardiac workload increases, the angina could become even more serious. So this is wrong. Causing peripheral vasodilation to reduce afterload? It doesn't cause vasodilation. It doesn't work on the blood vessels. All beta blockers work only within the heart. They go inside the heart and reduce the activity of the beta receptors on the SA node. So it doesn't perform the function of vasodilation. Decreasing the heart rate and myocardial contractility. Yes, it does this. Because it will decrease the heart rate, as it will block the beta receptors that are on our SA node. It will block them. This means the heart rate will decrease. And the AV node, on the AV node, the beta receptors, it suppresses those too. Because of that, contractility will also decrease. This means the heart will have to apply less force and the heart rate will be lower, so it will have to do less work. This means the cardiac workload has decreased, which is what we want. So this means that atenolol or beta blockers decrease the heart rate and decrease myocardial contractility. This means they reduce the heart's workload. This means they will reduce the oxygen demand within the heart, reducing platelet aggregation in the coronary arteries. That is, it doesn't aggregate platelets in the coronary artery. That's done by antiplatelet drugs like aspirin and clopidogrel.
Before we move ahead, here's something you shouldn't miss. If your goal is to pass the NCLEX in just 1 week or 1 month, then the fastest and most effective way is to enroll in our complete online NCLEX review crash course. This course is a one-stop solution, a reliable shortcut, and a proven method with a solid 99% passing rate. More than 5,000 students have successfully passed the NCLEX by using this course. Here's exactly what you'll get. 100-hour mini crash course perfect for those who want to pass within a week. 300-hour comprehensive lectures covering 300 essential NCLEX topics that are commonly tested. 5,000 real NCLEX questions. Prepare with real exam questions and eliminate surprises. 15 full practice tests, including CAT simulations, simulate the real exam for a stress-free experience. Exclusive ebook plus 1-year access. Study whenever and wherever you want. Seats are filling up quickly. Enroll now to save 70%. Visit our website to enroll in our complete NCLEX review crash course. The link is in the description. Now, let's continue with the topic.
A patient with angina pectoris is prescribed sublingual nitroglycerin. The nurse provides teaching about how to use the medication during an episode of chest pain. Which patient statement indicates the need for further teaching? This means we have to identify the incorrect statement. This statement will be our answer here. If my chest pain continues, I can take up to 3 tablets, 5 minutes apart. Yes, we can take 3 tablets with a 5-minute gap. We can give nitroglycerin 3 times with 5-minute intervals. So this is a correct statement. While this statement is correct, the question asks for further teaching, meaning the incorrect statement will be our answer. So this one is wrong. I will place 1 tablet under my tongue as soon as the chest pain starts. Yes, this is also fine. This is also a correct statement that as soon as the pain starts, he can place a tablet under his tongue. So this is also correct. However, we need to find the incorrect statement. If my pain is not relieved after the first tablet, I will wait 30 minutes before taking another dose. No, because if the patient had pain and took 1 nitroglycerin tablet, and if after 5 minutes, you shouldn't wait that long, because if you wait 30 minutes, this angina pectoris can become more severe and turn into a myocardial infarction. This means this is the incorrect statement, so this will be the answer here. If my chest pain is not relieved in 5 minutes, I'll take a second tablet. Yeah, if there's no relief in 5 minutes, he can take the next dose. A patient presents with a new onset of chest discomfort. The nurse is assessing the characteristics of the pain. which finding most strongly suggests that the pain is cardiac in origin. This means the pain is cardiac in origin, meaning it's due to the heart or it's angina, a burning sensation in the chest that improves after taking antacids. If the pain decreases after taking an antacid, it means it's gastric, so we'll eliminate this. A dull, pressure-like pain that radiates to the left arm and jaw. Whenever a patient has angina pectoris, the pain will be referred pain. Referred pain, so it will either go to the left arm, the neck, or the jaw, and that pain will be dull, not sharp, but dull. So that means this will be the correct answer here. A sharp, see, as we said, it won't be sharp, so you can eliminate it right here. Or a brief pain that worsens with coughing or deep breathing, meaning pain that occurs with coughing and deep breathing is pleuritic pain. Pleuritic pain means it's related to the lungs, so we'll eliminate this too. Localized chest pain that increases with palpation, meaning when you palpate something and it causes pain, that's not heart pain, right? We'll eliminate this as well. A patient presents with recurrent episodes of chest pain lasting about 5 minutes. The pain is typically triggered by physical exertion and is relieved by sublingual nitroglycerin. This means it's stable angina pectoris, because it's predictable that the pain will be relieved by rest or by nitroglycerin. The electrocardiogram is normal at rest. This means that the ECG is normal at rest. Which of the following is the most appropriate test to confirm the diagnosis? So, how will we confirm this diagnosis? Cardiac enzyme testing. So, in this case, all these symptoms are indicative of stable angina because they are predictable, meaning pain occurred during exercise and was relieved by rest. Furthermore, whenever the patient had pain, we gave nitroglycerin and the pain subsided. This means that the pattern of the pain is predictable. But since it's predictable, what does that mean? This is a case of stable angina pectoris. So we need to look at angina pectoris, specifically checking for the stable type. So we need to perform a test where we can observe that when we increase the heart's demand, chest pain should start in the patient, or ECG changes should begin to appear as the demand increases. So, which test will we perform for that? Cardiac enzyme testing, troponin. Now, troponin's usually used, mostly in cases of MI, which is myocardial infarction, when the heart tissues are already damaged, whereas here, the heart tissues are not damaged. This is a condition of ischemia, meaning a lack of oxygen. So that means we won't be performing this test here. Next is the exercise stress test. In an exercise stress test, what happens is that the patient is made to exercise on a treadmill. Now, as they exercise, the heart's demand for oxygen increases, the heart rate goes up, and so does the demand. Then we observe whether the patient experiences any pain. This will give us an idea that the patient was fine initially, but as soon as we increased the demand through exercise, chest pain started, and once we stopped the exercise, the pain was relieved. This means that we'll perform this specific test, which we call an exercise stress test or a treadmill test. Cardiac MRI is not specific in this case. Holter monitoring involves continuous ECG monitoring over a 24-hour period. A patient with unstable angina is receiving an intravenous nitroglycerin infusion. Here, you must note that an intravenous infusion is being administered. It's intravenous. This means your answer might be slightly different now. This is an IV nitroglycerin infusion. It's ongoing, and the patient has unstable angina. Unstable angina means it could progress to myocardial infarction at any time. This occurs when there's significant blockage in the coronary artery or if a fatty plaque ruptures, potentially leading to a clot. So it's unstable angina, and an IV infusion has been started of nitroglycerin. The patient reports a severe throbbing headache after the infusion started. What is the nurse's priority action? What should the nurse do first? If we had given the patient a sublingual nitroglycerin tablet, we could have stopped it. But in this case, the patient has unstable angina and a severe throbbing headache, so we can't just stop it, as doing so might cause the patient to go into MI. So what will we do for this? Option 1, administer acetaminophen for pain relief. It might provide some pain relief for the patient, but the root cause needs treatment, and we haven't addressed the root cause here. What about this? Stop the nitroglycerin infusion immediately. If we stop the infusion, the condition will worsen. Decrease the infusion rate and reassess the patient. Yes, we can reduce the rate of the infusion. Then, after a while, we'll reassess to see if reducing the rate helped relieve the headache or not. Administer a caffeinated beverage. If we give a caffeinated beverage, what will happen? Activity will increase, meaning the heart rate will rise, which we don't want. A higher heart rate increases demand, so we'll eliminate this too. A patient diagnosed with angina pectoris has been prescribed nifedipine. Nifedipine is a calcium channel blocker, and these calcium channel blockers block the calcium channels in smooth muscles. This means calcium can't enter the smooth muscle cells, which prevents them from contracting. So they primarily cause vasodilation, which in turn helps to lower the blood pressure. The nurse is providing discharge instructions regarding medication management. Which instructions should the nurse include? Inspect your gums regularly for any changes or swelling in the gums, meaning check for any swelling or changes in the gums. The patient should be told to keep an eye out for any changes. Now, yes, this medication, nifedipine, can cause gingival hyperplasia, which means it causes swelling in the gums. So the patient must be informed that if gum swelling occurs, they should note it or report it. Therefore, the correct answer here is A. Limit the intake of green leafy vegetables. We don't typically tell patients to take such precautions like reducing their intake of green leafy vegetables. This is usually advised for patients on warfarin, so this option is also incorrect here. Monitor your blood pressure once a month. Once a month is far too long. Frequent monitoring is required, not just once a month. So this is also wrong. Weigh yourself daily at the same time. There's no need to monitor weight with this medication. The physician refers a client with unstable angina for cardiac catheterization. This means the patient is undergoing cardiac catheterization for their unstable angina. The nurse explains that the purpose of this procedure is to... What is the purpose of cardiac catheterization in the context of unstable angina? To open and widen blocked coronary arteries. In a cardiac catheterization, we insert a catheter into the patient and then visualize the coronary artery to see the extent of the blockage. So this means the answer here is B. Option A, which is to open and widen the blocked coronary artery, basically opening the artery or removing the blockage, that's done mostly during an angioplasty. To bypass the obstructed blood vessels, meaning if there's an obstruction in any small blood vessel of the coronary artery, they bypass it and place another blood vessel there. So bypassing is mostly done in CABG, coronary artery bypass grafting, to evaluate the heart valves and muscles. This too. Heart valves and muscles, because it's angina pectoris, we don't need to look at the heart valves and muscles. We need to look at the coronary artery. So that was today's topic on angina pectoris. We'll meet tomorrow to discuss a new, very important topic. Thank you.